ACL injuries in women's sports. Boy, are they making headlines at every level, from youth athletes to pros. But what if the ACL isn't the real problem? Today's guest is one of the world's leading experts on anterior cruciate ligament injury prevention, helping shape programs used around the globe. Man, join us as we explore what these injuries reveal about how we are training, coaching, and developing athletes. Please welcome Dr. Holly Silvers-Granelli.
Thank you for having me. Mhm.
It's great. Holly, let me ask you, you know, this might be a difficult question for you because you're all over the place on this conversation, but if I gave you the power to eliminate every ACL tear in female athletes tomorrow,
Yes.
what is the very first thing that you would change? Not in medicine, but in youth sports.
I think sports specialization. I think that has been one of the major obstacles we're trying to overcome is that we have athletes that are specializing out far too early in their physiological developmental career essentially. So, when we were growing up, it was very, very common to be a 2 or 3 sport athlete. There were defined seasons, there was a lot of sport and movement diversity. Your physiology is still developing. We have these growing athletes that are skeletally and physiologically and neurologically immature, and we're treating them like elite NBA players, playing playoff basketball. It's medically negligent. It is negligent. And I say that really strongly. Earlier in my career, I used to be a little bit more soft in my language. And now we're being firm because we have athletes. I had a bunch of athletes just playing Surf Cup this past weekend, 5, 6 games a tournament. If I told any one of my professional soccer players, you're going to play 6 matches in the course of 72 hours, their heads would explode. And so why are we doing this to a developing athlete? So I think for my one of the main obstacles, and it's difficult because it's a business, right? Where there's this engine behind tournament play and sports specialization and club sports for every sport. This is not unique to soccer or basketball. Maybe the one outlier is American football because it tends to still be a bit seasonal, which I love. But we have to have kids have better movement diversity and let them have seasons. One, to avoid overuse injury, but secondly, to avoid like emotional and psychological burnout.
Terry, how happy are you that she
Oh my
started
God.
out with the worst problem that we have in our office?
I'm in love with this girl right from the beginning. I'm like, this is like the best thing ever. Based off of that comment, we hear so much from all medical professions, not just the medical and orthos, but we'll hear from chiropractors, PTs, and everybody always focuses the knee, how to build the knee stronger. But nobody's talking so much about the hip, the trunk,
Mhm.
movement patterns, and even brain mapping. Can
Mhm.
you elaborate a little bit on that?
Oh, I'm very excited about this because I think what we've learned. So I'm a PT, but I have a PhD in biomechanics, and I did my biomechanical studies 15 years after I commenced my PT practice. So I was an older student, or the matriarch of the program, if you will. But what was so amazing about that? I was able to prove my own hypotheses, right? I had been practicing for 15 years, and it was wonderful to go back and say, is what I know, or is what I think to be true, what I know to be true? And we were able to really look at the 11 plus program in particular. So that was one of the injury prevention programs that we developed for FIFA back in 2005. And it is immensely effective at reducing not only ACL injury, but all soccer related injury, including concussion. We have a paper in peer review right now looking at, and that has to do with having just better all over movement control, like better trunk capacity. When you're going into a purposeful header, do you have neck flexor control? Are you able to synergize that with your rectus and your TA? And these are all things we can't look at this as a micro problem. It's a macro problem, right? It's not just the knee. It's not just a foot and ankle issue. It's an overall movement propensity issue. And, not to beat the dead horse, but essentially when you have kids playing one sport all year round at a very early age, we are missing immense opportunity for coordination and neurological motor control. What is the prefrontal cortex doing here? And then what I've been really getting into more recently, and partly because I had my own injury about a year and a half ago, is really looking at the autonomic nervous system and how we look at that not fear-based, because you have to be careful here, because when I talk and educate my athletes about HRV and heart rate and their sleep and looking at the components of deep core and REM, it's not to scare them, not to wake up and be like, oh my God, I didn't sleep well, my HRV's in the toilet. And it's not like I have to bubble wrap that athlete for the day. It's more like, okay, now I train smarter. I train smarter knowing I had a glass of wine last night. I traveled internationally last night. I I have a little bit of jet lag. I may be dealing with an underlying low-level cold. How is that affecting my autonomic nervous system? How does that affect my decision making on the field? How does that impact my injury risk for the next 24 to 48 hours? This is the level of sophistication we could get to now, because everybody has access via Aura, Whoop, Fitbit, Garmin, Apple Watch, or whatever. In team sports, we have Catapult and very sophisticated measuring or diagnostic metric systems. So I think that's what's really fun right now as a clinical scientist, as a clinician, really giving it's an empowerment, right? I want to pass the baton back to the athlete so they don't feel fear-ridden, especially in our female population. It's like, my goodness, I know I have 6 teammates that have torn their ACL. I worked with an elite club in LA, and there have been 8 ACL tears on one age group team in the past 3 years. Like,
Wow.
they're just waiting. I mean, it's nonsense. It's also it's bewildering and it's terrifying, because you're just literally waiting for it to happen to you. And we need to change the script here. We have to say there is an immense amount of scientific research that has gone into this particular injury. Here's what you can do about it. Here's what you can really do about it, because you can protect yourself. ACLs should not be normalized. ACLs are not a natural occurrence of sports participation. We collectively have created an environment to essentially make this more prolific than it needs to be. So we need to look back to 20, 30 years ago when this was not happening as commonly. What were we doing right then? And what are we doing incorrectly now?
We had 2 guests actually, Tim Hewitt and
Mhm.
Trent Nestler, and they both brought up the stats of it. If you brought it up, a concussion
Mhm.
within the first 3 years post concussion, you have like an 86% increased
Mhm.
risk of an ACL. And I remember bringing that information to both my colleagues, PTs, and orthos, and they looked at me like I was a deer with the deer in the headlight look. They had no clue. And then you talk about the hip mobility and foot strength, and they're like, they still preaching just ride a bike and develop hamstring strength to reduce your
Mhm.
ACLs.
Mhm.
And how frustrating is that for you when the research is out there and it's still
Mhm.
not getting to the masses?
It's really difficult. And I think I have a patient who's just this amazing clinician at Cedars. She's an MD, PhD, and she works in fetal medicine side. And she said to me one day, and it actually brought some solace to my heart, because oftentimes I'm beating my head against what seemingly is like a brick wall. Like, we have data. We have a lot of data showing that we can mitigate risk. We can't prevent them all, right? There will be some unpreventable injury, and we recognize that it's part of playing sport. But she had said to me they were looking at the utilization of dexamethasone to prevent essentially parental or female mortality during childbirth. And they came up with, literally, it was about a dose of dexamethasone that would cost $1.25 that would reduce infant and maternal mortality by 60%. And she said it took 20 years for that to become an actionable element of widespread utilization in the United States for maternal mortality. And I was like, why in God's name does it take 20 years to recognize research, get it into outside of journal form and get it into readable form, into podcasts like this or the New York Times or wherever people are getting their information from, is 20 years acceptable? And she's like, it's just sort of what's been established. So in some ways I got a little solace. I'm like, well, we're 26 years in. We're not we're not too far from that. But what's mind-boggling to me is that we have the data. We have partnered with the biggest sporting organizations in the world, FIFA and the IOC, U.S. Soccer. We are now embedding it into coaching curriculums, but we still have reticence of coaches to, utilize injury mitigation. So I realized, I think clinicians in general could be the worst salespeople imaginable, me included. So I'm like, I've got to work on my sales pitch. So we started looking at the performance metrics. They said, okay, look, if ACL mitigation does not excite you as a coach, which it should, but if it doesn't, we'll consider that case scenario. How about we talk about what happens to your team and individual performance as a result of utilizing this program? So when we developed the 11 plus, we first studied it in women in Norway, young women, about 14 to 18. And we were immensely successful, like reductions of like 50% of injury, severity of injury was down, time lost due to injury was down. So then what was interesting, I think you guys will appreciate this because this was like the mid 2000s. When we started presenting this data globally, I would get direct questions. Well, like, Holly, well, that's great, but where's your male data? And I did find a little irony in that because it never is sort of studied in women versus men. I was like, okay, appreciate that because we can't extrapolate to another gender just because we think it will work. We have to show some data. So we did this study in Division I and Division II men, and one of the more fascinating data points was, hey, let's look at the program in totality. And again, almost identical to the female data, 72% reduction in ACL injury, 55% reduction in concussions, in hamstrings, significant reductions in concussions. But what was fascinating from a neurological perspective, we said, what happens on the day of utilization? So we looked at the intervention group, so the male athletes utilizing the 11 plus, and the day of utilization, injury rates were even lower. Severity of injury was even lower because we're neurally preparing these athletes for competition. It's fascinating because a lot of times we'll get a criticism from the coach, well, I don't want to do this on a competitive day. We'll only use it in training. And I'm like, you are missing an opportunity because we know injury rates are higher on competition day, right? You're preparing the brain just like you would prepare a muscle, and it is of equal, albeit maybe more importance to prepare neurologically for sport than it is muscularly. We could argue there, but I really think, at more than half of orthopedic problem or issues are neurologic in nature, probably even a higher percentage. But the performance data was really fascinating. So we looked at wins, losses, and ties. And what we found, not surprisingly, is the teams that had very good compliance, so utilizing the program two times per week or more, were winning more. We're losing less. And so I'm like, aha, there's our carrot. So now we're going to go to these coaches and say, hey, we had a Division II team that won the national championship that year. Now, are we as a group, are we making these athletes better? I do think we are. And we have some data to show like some coordination and proprioceptive benefits, obviously some strength benefits, that's there. Does that translate into full technical prowess on the sport? That's a hard metric to measure, but that's arguable. However, you're winning more because your bench is full. You're looking down your bench and everyone's available to you. And look what happened to the Knicks this season. They were healthy. They were available for play, right? And we can look, you talk to any great coach, and what is their biggest asset is player availability. Players that are healthy late in season. So that's what we have to say to coaches. Like, hey, and I plead with my coaches now, you are on the field ambassadors. You are the most important person in the equation. We've done all the science. We've been pounding the pavement for 26 years. Now we have to, it is your due diligence to do so. And we also talk to coaches in that, look, let's talk about your job description. Is it really very simple to say we want a coach that will focus on player development and tactics and strategy and look at formations and, hey, make sure we get some wins in the win column and less losses? Or do we broaden that? And are you really responsible for player health, safety, and wellness as the number one component of a good coach, right? To look at these growing athletes and say, hey, when you're my age, when you're in your 40s, your 50s, your 60s, you still want to be athletic. We know when you suffer an ACL injury, in your early years, in your teens or 20s, your mortality is impacted. You die earlier. And that's probably because of arthritis and life changes, and you're moving less when you're 60 and 70. So that is not acceptable. We can't accept this high rate of injury that's happening so early in life and just say it's a price of doing business, because I find that personally medically negligent.
Oh, love this.
Yeah, no, I love this. This is now not to use fear as a tactic to motivate
Yes.
some of our listeners and viewers, but you mentioned earlier about the excessive activity in one sport throughout, perennially. So you got, we have players, whether it's tennis, soccer, lacrosse, and they come in and they go, uh, I practice 5 days a week, and they go, oh, that's great. What do you do on the weekends? Oh, competition. So now you're talking 7 days a week throughout the throughout the year if it's not high school or a club sport, and these are
Right.
young kids that are coming in. So I agree immensely. We talk about cross training, but here is an important factor that parents don't realize. As good as their intention is to get the kid to do a cross training, we had one, actually the physical therapist in our office was treating a 16-year-old that was it was a breaststroke swimmer that was preparing for Junior Olympics, her first time, and she was a rock star in swimming. But the parents said, you know what? What a great idea. Why don't you cross train, do something different in a sport? Well, she did. Flag foot flag football, tore the ACL first time out there. Why? Because you took a kid that is in a non-weight bearing sport like the breaststroke and that strange movement that circumduction they do with the knees and their legs, and blew it out. So with all that's going on, how did this come to an event where athletes are playing the same sport all the time?
Yeah, I think we have to say it's a business. I think it's honestly it's a financially driven model that behooves, you know, the people in charge from a capitalistic perspective, because we're not benefiting our kids. I'll give you an example, and this is a personal example. Full transparency, and the reason I got so embedded in the ACL injury world is, those of you familiar with soccer, my brother-in-law is Tony Meola. So he's a three-time World Cup athlete, he's a goalkeeper for the U.S. men's national team, was drafted by the Yankees out of high school, and he was the Parade American three sport All-American in baseball, soccer, and basketball. He was an enigma. Those athletes they aren't created now because we're not allowing them to be created. There won't be another Tony Meola because Tony Meola wouldn't be able to play three sports in high school and excel. His kids are equally amazing athletes, and my sister, to be fair, they got good genes on both sides. She was an amazing athlete, so they just had. But when my youngest nephew, who is a third baseman at Oklahoma State now, when he was in high school, his baseball coach was like, do not play basketball. You are going to get injured. We need you for the postseason. And my sister said, I think you need to talk to my sister because she will beg to differ. And we got on the phone and really had a great conversation about why it is important for young athletes to do more than one thing throughout the course of the year. When you take a baseball player, particularly a third baseman who throws essentially just as hard as a pitcher, and you do not allow them to do something else other than that, we are going to create some problems as they continue in their career, right? So, and just to mention like what happens psychologically to these kids, the emotional and psychological burnout that comes along with doing something repeatedly since you're 10 years old, over and over again. And a little anecdote to your story, Spencer, like I remember Lenny Krayzelberg, right? Remember when he tore his ACL on a treadmill? It's like, I call them my mermaids. If you're a fish, you have a little trouble with terrestrial sport, but we have to be careful there because we train them accordingly because you need to be able to hike and walk. But there is this element of sport specificity, but that was created and now we have to unravel it, as opposed to let's give broad exposure to developing athletes throughout their development. So Ajax, that huge club in Europe, perhaps I think the first club in Europe, if I'm not mistaken, to create the academy system, right? They had the sort of developmental academy where you could be on campus or, in Holland. Obviously, the geography is a little different, so you could commute in, but there were some athletes that were sort of on campus going to school and then doing dedicated training. So they did a study and they looked at how successful are we at creating Premier League, Serie A, Bundesliga players. Like, how can we identify our youth in a way that if we're picking them out, if we're siloing these kids at like 7, 8, and 9, how successful are their careers in their 20s? And what they found is that they actually weren't very good at it when they were selecting that young. Where they got really good at it was precisely 15.2 years of age. When they were taking kids that were playing netball and doing cross country and playing other sports and having fun and being a kid and developing physiologically and letting their skeletal maturity happen without year-long stressors, they're biking and they're doing all of these things that are fun, and they're part of their social cohort without being sideloaded to an academy with kids from all over the country. That is how you do it. And all of those guys, like, look at Holland. He's a perfect example, tearing it up for Norway right now. And he played 2 or 3 sports going up to when his signing with Man City. There are so many examples. Patrick Mahomes, there's so many examples of how to do it well. When we start playing one sport, that's where it tends to go wrong. So I really think we as a community of professionals, we have to impress upon the coaching communities and the parental communities, because I think it's hard once you get on that train. If your kid is selected for a club sport and you're like, hey, John is missing tournaments because he's playing another sport, he will lose his spot. So how do we counsel the parent to maintain their child's spot on the roster when they're doing the right thing for their child, but they're going to be ostracized by the club? And that is the difficult thing. And I have these conversations with parents all the time. And I say, look, it's going to be difficult. I'm happy. We do these one-on-ones with coaches. And I'm like, you are doing yourself such a great service to let this kid have exposure to different types of movement. This kid will be a star, or just be healthy. We'll keep it at that. I can't promise stardom, but we can say this kid will be healthier and emotionally more healthy and psychologically less burned out if we allow a diurnal or triurnal component to their calendar. It's so logical, but we've gotten away from it. And really, I think, sadly, it's money driven, because there is a lot of money to be made.
I'm so glad you brought that up, Holly, because I think parents have FOMO. They see somebody else, that kid is rising and hired a trainer and hired the nutritionist. Well, I better do that because, I have to, he'll never make the Olympics if he doesn't, start now at 8, Did you see that documentary or that side thing during the Winter Olympics where they went to Norway and they wanted to know why their athletes just crush it in the Winter Olympics? And they were talking about, well, we don't do participation trophies, which everybody in the United States hates, but we just let kids compete and nobody wins, nobody loses, which people think of participation trophy, but we let the kids develop doing everything and having fun. And it's always a family picnic. And when they race, they're cheering last place as much as they're cheering first. And they wait till the kid develops to find what their passion is when they hit their medal, and then they start focusing and driving and putting them into some. But from 15 under, they're all put in for fun. And there is no competition. They don't believe in competition. They believe in fun. And I thought that was extremely interesting because the kids develop so strong. That's why they dominate the Winter Olympics. That's why they're crushing it in the World Cup right now. What are we intentionally, besides singling the sports, what we, especially getting back to female athletes, what are we intentionally doing here that is causing so many ACLs in women? What are we need to change besides yearly sports? What else?
Yeah, it's a great question. And I did see that documentary. And again, another, proof in the pudding in terms of like, look, I think we have to be really careful about reading information that feeds your own narrative, right? You're going to have the one-off, the outliers of like people who, were identified early and went on to elite, performances. But for the most part, most of us sapient beings with normal genetics are not going to do well under those conditions. We will do far better under exposures, broad exposures, right? So from a female athlete side, when we started getting into this work, and again, this is the early 2000s, Edie Griffin, who's an orthopedic surgeon in Georgia, just an immense talent. I love her. She's a visionary, really. She put together this thing called the Hunt Valley Conference, which Tim Hewitt was a part of as well. And we essentially sat down and said, okay, let's just start identifying risk factors. We didn't know much then, right? So we looked at 4 risk factors. Specific for women, we looked at environmental risk factors. So that would include turf versus grass, hardcore, is it over ice or not? Like looking at friction coefficients, essentially, shoe wear choice. Then we looked at hormones in women, like what happens during the menstrual cycle, during ovulation, when we have the peak in estrogen, a week later when we see the peak during luteal phase with progesterone. Is that changing ligamentous properties? What do we do during those cases? Then we had anatomic issues to consider. Like most women, their intercondylar notch is going to be a little more narrow than men's for the most part. Generally, we talk about Q angle. Hip width, I like to say hip width to femoral length ratio is different in women as opposed to our hips are wider, because that's not totally totally true. But also the ACL diameter tends to be a bit more narrow in women. Again, these are non-modifiables though, right? So, but how do we think about that in a way with the 4th risk factor, biomechanics? How do we now take all of those variables? Some are modifiable, some are not. And how do we neuromuscularly train an athlete to offset the risk from some of those other variables? Now we've extrapolated that framework, and we've now included genetics. So we know there are some athletes where they have had 1 or 2 parents tear an ACL or a sibling. What do we do with them? We don't drive fear into them. We just say, okay, here's a certain set of genetic markers that are unique to you. How do we help you more, right? You're going to need a little extra guidance than maybe one of your teammates that doesn't carry that genetic or that epigenetic load. So we want to think about you maybe a little bit differently. Then we had the whole medical resources and acumen component. So in other words, this became a little bit more popularized during the Women's World Cup in New Zealand and Australia a few years ago, because it was pretty shocking when you looked at the number of talented players that were like Ballon d'Or nominees that were not available for that tournament because they were out with ACL injuries. It was pretty shocking. It was like 10 of them, 10 of the top 50. So that's a huge percentage of immense talent unavailable for, their biggest event of their lives. So we wanted to say, okay, are women being under-resourced from financially? We know about that from a salary perspective, and that's actually, I think we've made a lot of headway in terms of like women's equal opportunity in terms of funding opportunities. But also, what clinicians does the U.S. women's national team have available to them compared to the U.S. men's national team? Like, are you getting Terrys and Spencers and Hollies and Burt Mandelbaums, or are you getting the B team? I'm not saying that in a disparaging way, but it's realistic, right? So do they have access to medical excellence, or are they getting people that are perhaps less qualified or less seasoned, less tenured? And then, that famous, so it must be 3 or 4 March Madnesses ago when they showed the snapshot of like the women's facility for the March Madness tournament, which consisted of a yoga mat, a Swiss ball, and a weight sack, compared to the 25,000 square foot, facility that the men had access to. And like, so that, I think we've really made some immense headway there in terms of shifting that script, because I think we've really, in a very good way, of taking care of that variable, and still has some growth. But you look at the Michelle Kangs of the world dumping a ton of money into female research, and that's been wonderful. The 7th variable, which is newer, which we touched on earlier, is the autonomic nervous system, right? How does HRV, heart rate, how to sleep, how nutrition, hydration, all of these variables, which we know of, but how do we measure it? And how do we take that number? I really do love HRV because I think it's an incredible proxy for the autonomic nervous system in general. And how do we build that in, just like we would? How many sprints did you do? What was your loading like for the last 5 days when we look at acute and chronic workload? Did you have a death in the family? Did you break up with your significant other recently? Like, how do we fit that in? Because it's important. And not to be hyperbolic, But I think there's been this bias. When I teach my athletes, you have 4 pillars. When we think of our well, when we wake up for the day, how full is your well? Do you have a lot of water in your well? Are you halfway full? What's your gas tank like? So we have to think of, there are emotional components to draining our well. For our student athletes, did you have a test? Do you have an exam? Did you not perform well? You have your cognitive components to your well. Like I said, did you have, are you in the middle of finals? You have your social context. Did you go out? Did you have a cocktail hour? Did you have a big meeting with a group of friends? That can draw from your well. And for some of your introverted players, that will draw very deeply from your well. So you have to think about that. And then there's the physical component, right? Which we're all familiar with. And that's been our bias for years. How much did you drain yourself physically? But we've sort of not paid attention to those other 3 components to the well. And we have to, because they play a very important role of how they impact the vagus nerve, how they impact HRV and heart rate. So all of that gives us a very high level of sophistication, saying, yes, we know how to neuromuscularly train. We've proven that. I really do believe that. But have the people we weren't helping well, or the re-injury rates, have we not been paying attention to the other components from the neurological aspect, or the ANS in particular, to say, hey, we've got a real opportunity here to even shift our numbers even higher with respect to protectionary efforts. And I think the data, we're about to publish something in the next 6 months on this, because it's really, really exciting. And I think that will be another component to how we help athletes recognize how full is your gas tank, how full is your well. They can manage that, and then they can say, it doesn't mean we bubble wrap them. That doesn't mean, oh, you do not train for 2 days. You're off the field. Your HRV is 42. You're not optimal enough. No, it means, do I go in for that 50-50 ball on training, or am I going to pull back a little bit because I know today's not my day? That's the beauty of it, because it's self-empowering. That was a very long answer. I'm sorry, but
No, that was
And a
beautiful.
good one. No, that was great.
Uh-huh.
I do have a question. You are the voice of reason, so I'd love for you to comment on something that is very suspect and sneaky in the realm of overtraining. Now, yes, we all agree that, one sport perennially is not good, but to cross train and be selective about which sport you're choosing. But you know I'm in South Florida, and that is like the mecca of off-season training, because there's so many athletes that come down here. But what I noticed was so frightening several years ago, and that is when a private coach or a trainer or a strength and conditioning coach is hired by an athlete to do weight training or conditioning, away from their, obviously, when they're off season from their sport, that coach or that strength trainer is looking to make a mark, and that mark is usually to overtrain or to show how rigorous the training is for that athlete. And I've walked into this and seen, players discuss how, man, training was hard. I don't know if I can, come in tomorrow and all that. How detrimental is that to when the season starts? I would love your thoughts on that.
That's immense. And I think there's so many aspects to that question that I love, because I think it really deserves illumination, right? It deserves the respect that we need to give it. One of the things I love about being a female clinician is that, and this is going to sound reversely misogynistic, and I don't mean to sound this way, but I think I have no ego in the game. I love what I do. There's no, and I mean this not in a hokey way, that I get no greater benefit as to seeing one of my players go back and play their first game. Like it just, I just recently worked with one of our NWSL players, and she had a long journey, like 3 ACLs over her collegiate career. She got signed, and I was at her first game professionally, and I literally cried. And I say that I am a sappy person by nature, but I was just so happy for her. And it's not about Instagram. This has nothing to do with me. I got so much joy out of her having joy. And as clinicians, That is our exact role. It is silent. It is private. It is like you're their proud aunt or uncle, cheering them on from the sideline. You are not looking to make some indelible mark on their physiology and say, oh, because I was the person who trained them the hardest. That is your ego. That is your narcissism. And that is your selfishness getting in the way of what is best for that player. So you need to be introspective and interoceptive and recognize you are doing a bad thing because you are being additive to the problem instead of, mediating it. So we're working with Tim Noakes, who is a surgeon in London, who has taken the PEP program. So the PEP program was one of the ACL prevention programs we developed first, specific for ACLs. We studied in Southern California, really effective program. And they took this and they created a program in London, in the greater London area, called Perform Better. And they're doing this like really wonderful grassroots outreach within their academies and within their grassroots community. He, as a postdoc student, I think this is brilliant, is looking at those three components: narcissism, egotism, and selfishness in coaching. And I say that objectively, right? It's fascinating, right? How good is that? And I'm not exactly sure, because I want to get into the nuance of his algorithm. I want to see how he's actually capturing the metrics in a numerical way. I don't know the nuance there. I'm so excited to read his doctoral dissertation, but I think, like, if you look at the Pep Guardiolas, the Mourinhos, like all the greats, Zidane's, like people who have had success, and they have a lot of those elements, right? They're larger than life characters, and they bring. But how much of one of those qualities is too much? Is too much selfishness preventing you from saying, oh, perhaps how I played as a player 25 years ago, not optimal right now because we have better science and data tell us otherwise, right? Oh, and just because, oh, you need to go hard, these kids are so soft today. Maybe that's really not the answer. Maybe it's like we are recognizing scientific metrics in a more sophisticated way than we were in the 70s and 80s, and that's probably the more logical answer. So I think as a coach, you have to recognize, hey, I tend to have a larger ego, and that makes me a good coach. But does that large ego make me a little perhaps reticent to adopt something that might be a little more novel than when I was actually a player and being coached? And I think that is an important part of coaching curriculums. We have to have this nice discussion with saying, hey, all of your qualities get you to this point. You're coaching Division I, you're coaching professionally, you're coaching at this level. And yes, those characteristic traits have gotten you to this point. However, there is a body of science here that is going to be protectionary that will actually help you in the win column. So let's bring it all in, right? Let's bring it all in. So I think, again, very long-winded answers for you guys. I could talk to you for 10 hours, but but I think that's really a cool aspect to how we're looking at coaching, how we're looking at their ability to integrate sort of more novel scientific physiologic concepts that may have not been even measured when they were indeed playing, and how we make those presentable and palatable in a way that will help them on the performance side. And the wonderful secondary benefit is those individual players are going to really benefit from it.
Holly, when you watch a game, and this is an answer for parents, but also for yourself, is when you're watching game film of an ACL, an ACL injury happening, or can you identify certain movement signatures that have existed, maybe months or years beforehand, before the actual injury? Because before you answer, what I read some time ago. It was some research that they did MRI on those that had ACL tears and ACL and post-op ACL surgeries. And what they found, and I think Dr. Terry mentioned it earlier about, brain mapping. An athlete is so used to guarding that one almost tear or a subtle discomfort or even just biomechanical errors or faults before the actual ACL tear, that it's starting to change brain patterns. So now the surgery is maybe the surgery is done, or there's been some rehab, where most rehab is strength training, isokinetic testing. Remember the Cybex machine and how fantastic that was regarded at some point. But there's so much more, like proprioceptive movements and things like that. But they saw on MRI facets of the brain that had changed because somebody, like if I put a rock in your shoe and
Mhm.
you couldn't get it out right away, you're going to limp or you're going to walk
Mhm.
funny. Imagine that athlete walking funny for a year or two beforehand. Can you identify certain, and now that's obviously, a blatant image of what happens, but can you identify those changes and what should a parent be watching for?
100%. So this is a little bit of a controversial subject because if you talk to Dr. Raul Bar, who I love from Norway, he has been kind of firm on, hey, are we from a pre-season physical perspective or a pre-screening participation physical, are we able to identify high-risk athletes? And it's arguable, right? Because sometimes we can, sometimes we can't. So I think the sensitivity and specificity of our current testing protocol is not quite there yet. However, I think there's immense opportunity. So, in continuing those, and in fact, I think as we go further, we can continue to refine them. I'll give you two stories because I think they're worth the anecdotal time. So, when I was doing my PhD, I was at the University of Delaware, immensely sophisticated human performance lab. So we were looking at the 11 plus program and we were looking at it from a preseason, midseason, and postseason perspective. Like, what are we actually changing to get these incredible changes in injury rate and severity of injury? So we had two camps. We had males and females, but we had the intervention group that was utilizing the 11 plus, and then we had control groups playing D1 soccer that were doing their traditional warm up. And what we noticed were a couple things. Most of the changes were occurring in the hip. So to Terry, your earlier point, we were making more hip and trunk control pattern movements changes, which was essentially being extrapolating distally, right, to protect the knee, which we know to be immensely impactful. So that was nice just to sort of, okay, we can sort of corroborate our thoughts there. But I was working with this one Division I athlete, and the irony of ironies is her father was a sports medicine, non-operative sports medicine specialist. And I literally stopped a third of the way through the testing because I said, in good conscience, I can't continue the test with you because I really believe you're going to tear your ACL during this testing. And I wrote a long letter to her specific athletic trainer, to her father, to her. I pulled her aside and she was a little upset. And I said, no, listen, you have immense opportunity here. Like we're going to dodge a bullet here. And lo and behold, a month later, she wound up tearing. There are movement patterns that you can identify that are immensely deleterious. And if they're doing that in a controlled lab, we have a problem, right? Because when you bring into speed and competition, but what you said about the brain, which is fascinating. So the way I like to explain this, if we think of like the motor cortex here to here, right, headband, and then the prefrontal cortex, under traditional, like non-injured, non-painful circumstances, if we just talk really general, these are non-specific numbers, but I tell my athletes, say for example, in the non-injured state, you have 10% of your motor cortex devoted to your right knee, 10% to your left. When you have pain or you have an injury or you have an ACL surgery, all of a sudden that 10% becomes 40%. Now, my job with you to rehab you is to get that 40% down under 10%. I have to almost overcorrect so that when you get back on the field, you have the hard drive space to now extrapolate what the heck is going on around you. Where's that ball being deflected? Where am I making my run? How's that defender coming on to me? And that goes for every sport. This is not just specific to soccer. So if I don't have the hard drive space available to me, then I am at an immensely higher risk. The same thing why we have immense risk after concussion, because your brain is still operating under an injured state. So when we first started practicing and we're getting players back in like 5-6 months post, it was wild that we didn't have a higher re-tear rate than we do because we know the brain takes about 18 months, 2 years to fully normalize. And that's with doing dual and triple task activities. And this is with some like real sophisticated like nuance within the rehab sector. So that's how I explain it because people, I think Patrick Mahomes will become a case in point. Like he's out there on OTAs right now with a knee brace on. He's 5 months post, and we will get questions from parents. Why can my son or daughter not be doing the same? One, I don't know all the nuance of Patrick's case. I have nothing to do with it, and I'm just observing. But I would say, okay, well, he's getting treatment ostensibly every day, multiple times a day. But there's a portion of the neurologic system and the biological healing that we just cannot speed up. Like it is it is what it is, right? For all intents and purposes, and for all of the brain trust on this particular call, I don't think any one of us can say we don't have a sophisticated way to speed up the healing curve so much that we could have someone returning in 14 months and someone given the same injury. So I think a lot of my patient education comes around, let's teach you about how your brain is so involved in this injury, why it's so important. Secondly, I love Kate Webster's work on like the fear and confidence perspective, because you can have an athlete that's biomechanically testing beautifully, right? Force plate data looks good. All of our, whether using dynamometry or isokinetic testing, we're looking at all of their movement patterns. They're passing our 6 movement screen really well. They're dominating with their hip versus their knee, trunk movements looking beautifully. But I give them a return to sport questionnaire and they are still fearful. Then my goodness, we are holding that athlete out of competition, because at that point they are the center of this board meeting, and their ability to not have fear when they go back to the field, or to not have 100% confidence in their knee and their ability to perform, that has to supersede everything. So those are other things we need to consider, the psychological aspect of this injury, particularly if it's a re-injury, right? And we're seeing these more and more. I'll have a 16-year-old, she's on her second ACL. It's devastating, right? It's absolutely devastating. We're talking about, and how are they thinking they're going to get back out there? And the other interesting thing that we don't consider in youth sports, I've started talking about this, is like, not only are we rehabilitating this injury, now I have to get that 15-year-old back to 16-year-old soccer. The game's left her behind, right? She's lost a whole year of development, in addition to coming back from a really, a really pretty traumatic orthopedic surgical intervention. So now,
Holly,
yeah,
hey, Holly, you for a
sure.
second, you mentioned you started going into it, talking about that your
Yeah,
testing, that there's 2
yeah,
main things you look for that are
yeah.
precursors. What are those 2 things?
Well, I look for, from a biomechanical perspective, this is how I do and again, there's no gold standard. This is also interesting because I think this is always like shifting within the literature too. What are the best tests to do, how to do it? I think we all have our unique way of doing it, which probably isn't great either. But the way I think about it is, I'm a biomechanist, so I like biomechanics. I have force plate analysis, so I'm looking at various jumps. I'm looking at deceleration, which is incredibly important, because if you cannot decelerate well, we have a big problem, right? A lot of injuries, particularly American football, happen with that mechanism. I'm looking at strength parameters. Now, it is not just quad and hamstring. It is not just quad and hamstring. You have to look at lateral hip, external rotation, ABAD, plantar flexion, dorsiflexion. Look at everything. Like, it's a holistic injury. This is a holistic breakdown. The poor knee just took the brunt of it. So, and each athlete will present a little differently. So you have to do your detective work and find the missing link. And there may be a few missing links. So you have to do your due diligence, test multiple muscle groups. And then I talked about the psychological component, but I also utilize a lot of EMG, because it is my technical capacity to test the neurological system. And we can look at, okay, because I think what's interesting when we look at force plate data, and if we just look and we kind of look at peaks, right? We're looking rate of force development, those things. What I love about EMG is I like to get into the granular nuance and look at the peaks of, like, look at how much motor unit potential we're actually creating throughout a certain muscle group, but how well can they hold that peak, right? This is really important with hamstring literature. So if you look at hamstring, biceps femoris, and semis, right, and you're looking at doing a Nordic or a Russian, some sort of eccentric component, and they hit a high peak and they can maintain the peak and they slowly come down the curve, that's a good contraction because they can hold the contraction over time during a sprint. If you're looking at it and they peak and they drop off the face of a cliff, well, we have a huge problem, because that's the player who's going to have the hamstring strain in the 60th minute on their 14th run of the game. So we have to look at the nuance there. Look at the shape. Look at the impulse under the curve. All of these things are so important. Terry, I'm sorry, I'm giving you another very long-winded answer, but it's so technical in how we look at things. So I would say for the general clinician, and even if you don't have access to a sports performance lab, you do not. I have valved force plates. I love them. They're very inexpensive from a monthly subscription perspective to have, and they will give you some training on how to utilize them well in your clinic. Do handheld dynamometry. It's wonderful, and you can at least have some baseline strength data, and you can test multiple muscle groups. I use the M Trigger. I love that EMG device. They're a little over $400. Very, very palatable costs associated with doing some real sophisticated return to play and return to training testing that will give you another level of nuance that is outside of the general quad to hamstring ratio, and you looking at the glutes, looking at the nervous system, because it's so important. That I really fully believe if we were clinically to adopt a little bit of that more ubiquitously, our re-injury rates would fall precipitously.
Mm.
I want to ask you about wearables because they're
Mm.
massively popular these days. You mentioned earlier about, you spilled up, Whoop, Oura Ring, Apple Watch,
Mhm.
all that people are getting so consumed by. And I agree that there's benefits to, monitoring HRV and all that. But we we had Stacy Sims and Dr. Abby Ryan
Mhm.
Smith out of Chapel Hill on, and they both had mentioned something about, a lot of the data is driven by men, and
Mhm.
yet women are using it. But more importantly is women were much more sensitive and acute to their own personal feelings of, you know what, this doesn't feel right. So they can look at a watch and say, yeah, you got good sleep, or your HRV looks good, or good, good job, or a terrible job sleeping. But
Mhm.
that they're losing their sensitivity to their own, feeling of what's going on in their own bodies. And women are much more sensitive than men. Any thoughts or comments?
Oh, I completely agree. I think this is so interesting because I think women in general have a higher level of interoception, right? We just tend to be a little bit more tied to our bodies, and sometimes that's an immense benefit, and sometimes there's some downside to that. So when I'm working with my particularly like my high school and college age athletes, sometimes there can be a little bit of a preoccupation with like, oh, I feel this or I feel this, and like there's a conversation like, hey, you know what? Everything may not feel perfect. Like we pay attention, we respect symptoms, but we don't pay it too much agency where it deters us from moving or progressing. So there's a little bit of education there. On the flip side of that, sometimes I have high school collegiate age males that disregard everything, and they're like, "Oh, I'm ready, Holly." And I'm like, "Yeah, not quite, not quite." Like we're gonna. So there's this bravado cavalier slash excessive interoception spectrum that I always say, like, I try to wear two hats of like the psychotherapist completely. I say that in vernacular fun. I'm not by any means trained to be a psychologist, but I really have to read my patients well, right? Like I have to understand who's going to push, who's going to underreport, who just wants to get back to the field, as opposed to who may overreport and needs a little bit of my guidance and education and handholding to say, hey, this is okay. This is actually part of the process of healing, and to feel a little patellar tendon or quad tendon or proximal hamstring when you're coming back from something so involved. This is a normal part of like biomechanical retraining. So that is where the wearable conversation is really important. And I think I alluded to it earlier. You don't want to drive fear and panic with a wearable. If you know you didn't sleep well and you wake up and look at your watch and it stresses you more, that's not what we're trying to do here. It's like use it as an ally, not a foe, right? I look at my watch and they say, okay, I just traveled across the country. I had a glass of wine last night. I know my HRV may not be optimized. So this is the day maybe I don't push myself athletically, or hey, I'm doing this great podcast with two new friends, so I'm cognitively really engaged. I'm going to pull back from my well a little bit. That's just smart. That's just smart. I'm not bubble wrapping myself from life. I'm just saying, hey, I'm going to deal the variables in front of me and then do the best with my capacity. So I think like to take the fear, extrapolate the fear out of it, it's like everything's part of our equation. And I like to teach all of my athletes, they're like their own little mini PTs and biomechanists. They understand things. So then when they go to their respective clubs, if they wind up going professional or division one, that they can bring this information with them, and they're really empowered by it. That's I think my word for the day is just like making your athletes feel empowered and less fearful of the participation. I just wanted to share this one quick thing. I heard a story. I was in clinic on Monday, and I had an athlete tell me that some of her, she's an ECNL player, so playing very high level soccer, that some of her club players that have been verbally recruited as sophomores are opting not to play in club junior year for the risk of getting hurt and not being able to play collegiately. And I'm like, are we here? Like, this is where we're at, folks, that we are not going to participate for a year, to bubble wrap ourselves, miss a year of development, miss a year of social aspect, so you can go play D1 and be undertrained? This is insanity. I was gobsmacked, and I said, this has got to stop, really. And not to be hyperbolic, I really mean that, but this is really something we need to consider here, because when you have kids making this decision at 15 and 16 to say, I want to preserve my collegiate career, so I'm not going to play for 18 months, we have a massive problem because they've lost faith in the system. They do not think their club can protect them. And that is what we have to circle back. That is our message to the clubs. Your club, your kids do not trust you anymore.
Nice.
Thank you.
On that note, do you see with all the research coming around that we will get to a point where we can predict ACLs before they happen? And what does that future look like?
Yeah, I do. I think, like I mentioned earlier, I think as the sensitivity and specificity continues, and I think where clinicians get better, a little better with data reporting, and that gets a little bit more sophisticated, I think we will be able to, and as we can map the brain, so again, it's a little clunky now. You have to go into a pretty academic lab and look at M and H waves and do some, so that's like Ryan Zarzicki, Dustin Grooms, Meredith Chaput doing great work in this arena. But I think, how do we bring that to the clinic? And that's where I think those smaller devices, there's a lot of them like Naraxin, M-Trigger, Dorsav, a lot of companies, which I have no financial relationships with at all. I just like them. But that's where you can bring a little level of sophistication to your particular practice and be like, okay, hey, we're noticing a little differential in your ability to reach a peak and maintain the peak. And that will give us a little glimmer of like what's going on. Or your right to left differential, or your quad to hamstring ratio, or quad to glute looks a little bit disparate. And let's do some work there. So I think that will continue to evolve. We continue pushing the envelope. And I say to all the clinicians listening, I am still an active learner in my field, right? You guys paid me an incredibly flattering comment when we started this podcast, but I read every day. I am learning every day from all of you, because I continue to evolve my practice. I don't do things today that I was doing 5 years ago because I've evolved out of them. I've learned better. So please don't get dogmatic. Don't get entrenched in your own thought patterns. Continue to learn, continue to read, and continue to evolve your practice, because it just helps every young 15-year-old that will eventually show up into your practice that's really suffering.
Love that.
That's great. And that's why I think the curriculum in some of the schools, medical, even chiropractic, is a little antiquated, and they're still teaching the same darn thing. Whereas you're absolutely right, to continue constantly and never ending improvement. That's
awesome.
What we absolutely believe. Hey, Terry, now would be a good time to go into the rapid fire questions. Do you mind if we go over the hour?
Oh, I'm fine. Yeah.
Yeah. Terry, good?
I'm good.
All right. Well, this is one of our favorite parts. It's the rapid fire questions. Holly, I think the real challenge for you is to actually answer briefly.
You've gotten the trend of my verbosity.
Oh my gosh. No, it's fascinating. I love it.
Especially, the only thing I kept getting out of this show is that she traveled a long way and had a glass of wine before she met us. That's it. Because she brought that up twice. And if you have a glass of wine, liquor, HRV. So, I just think she partied last night before she hung out with us. And, I can't.
And she doesn't believe in bubble wrapping yourself. There you go.
No bubble wrap.
That's right.
Lots of wine and no bubble wrap.
There you
No
go.
bubble wrap, girl.
Yes.
Although
I'll just tell you one quick. My mom. I'm in the house I grew up in. My mom sadly had a cerebellar stroke about a month ago. So there's no prouder role in my life right now to be her PT. Like it's really been.
That's awesome.
Yeah. So
that's awesome.
Yeah.
Did you bubble wrap her?
I did not. We're doing stairs.
Okay.
I brought no wine for her.
I got goosebumps on that one. I love that. Yeah, that's awesome.
Cool. All right, maybe she needs a glass of wine. All right. So anyway,
Exactly.
One of those things have to have help, right?
Right,
All right.
Right.
All right. Rapid fire questions. There's 5 of them, and the answer, if you can, make it somewhat brief. But I
Sure.
will be honest with you. Sometimes it tends to get a little lengthy. But if you're ready for question number 1, here we go. You ready?
Okay.
Ready,
I'm
Holly?
ready.
All right. Between force plates, wearables, AI, video analysis, biomechanics, and movement screening, what excites you the most?
Oh. Oh, all of it. I don't know.
We
I
got her,
like it.
Terry. We got her.
I'm a
She's
Venn
gonna pop.
diagram. I'm a Venn diagram person because I truly believe, I'm going to keep this short, but I truly believe you will have an athlete that fits in each one of those circles with perhaps not the overlap. So if you get too dogmatic in one of those arenas, you may miss helping others. So keep it a broad spectrum.
Good. And that really is a testimony for the wearables that people like live their life on. But
Yes.
all right, very good. Question number 2. All right. One exercise every girl athlete should master. Oh,
Eccentric
here we go. I
hamstring.
think we got her, Terry. What was that?
Eccentric hamstring.
Oh, very good. Oh,
Yeah.
actually, very good. Very good.
Mhm.
Question number 3. One youth sport trend you'd eliminate tomorrow.
Early specialization.
She's doing pretty good. Huh? That's
Play
great.
multiple
crushing it.
sports.
Right on. Question number 4. Most overrated injury prevention strategy. What would that be? And then so the most overrated, and then what is the most underrated injury prevention strategy?
Okay, overrated would be to hire multiple people and do multiple. You're essentially overloading yourself to prevent injury because we've seen that, right? And I would say the most underrated is looking at free programs such as 11 plus PEP program that are done as uh, dynamic warm-up programs, take no additional time, are free on the field, and prepare you for competition directly thereafter.
Woohoo!
She's
She
crushing
is
it.
scoring big. All right, question number 5, the last one. One thing every coach that is listening can start doing this week.
You are a scientific ambassador. Please use the science we've developed. Use these programs. They're free. They will prevent injury. They will reduce injury time loss, and they will allow you to win more. Keep winning.
Wow,
Oh,
that's great. Hallie, I remember reading in the Times piece about you and the exercises is there something that people can refer to online that you suggest?
Absolutely. Great question. Yes. So, and maybe we could even provide some links if you guys make that
absolutely.
available. So,
Absolutely.
okay,
Oh, that's
we
great.
filmed this. I've done this for US Club Soccer, so we can provide a full video of the 11 plus in the PEP program. They are free. And then we partnered with the IOC, the Olympic Committee, and they created a app called Get Set. So GETSET. It's available for iOS and Android. It is free. If you download the app, if you look at football, because it's international, that is the entire 11 plus program filmed, ready to use on the field today.
Wow.
Oh,
Oh my
incredible.
gosh. You know, I just got to
That will
end
be
this
on
by
our description for sure.
Yeah, absolutely. I want to end this program on just telling you what a gift it is to have you on the show to inform the public what they are so unaware of in so many facets. You know, I read this New York Times piece. I read it, and it was titled something about women and why is there such an increase in ACL injuries amongst women? I'm reading all about your work, and I'm going, oh my gosh, I wish we could have her on the show. This would be unbelievable. And boom, Dr. Terry figures out a way to get to you. Thank you so much.
So wonderful. I really enjoyed our conversation. So thank you for having me
Same.
as a guest. Really fun.
Yeah, you're wonderful. Awesome.
Thank you. I appreciate that so much. I love what I do, and I hope that shows.
Oh, it does.
Oh, yeah. Yes. Yes.